In this video, we'll be focusing on the clinical pharmacogenomics of Clopidogrel or Plavix. And really the basis of this really comes from the FDA boxed warning on the package insert for Clopidogrel or Plavix, indicating that Clopidogrel does require a conversion process that is primarily mediated by CYP2C19. And there are certain patients that are CYP2C19 poor metabolizers. And among those patients, you might consider a different antiplatelet therapy or a different P2Y12 inhibitor in patients who are those poor metabolizers. So it's fairly rare for the FDA to even identify pharmacogenomic information within a package insert, but it's even more rare for the FDA to actually have a boxed warning about that. So we'll dig into that a little bit more throughout this video. In terms of what factors play a role in how effective Clopidogrel is, obviously CYP2C19 polymorphisms are well known in terms of how well Clopidogrel will be converted to its active metabolite, but there's a lot of other factors that also need to be taken into account. For example, there are known drug interactions like omeprazole that may impair the 2C19 pathway and make it so Clopidogrel does not get converted to its active metabolite. Ironically, cigarette smoking is actually a 1A2 inducer, and 1A2 is kind of a side pathway to allow for Clopidogrel to be activated. So ironically, cigarette smoking can actually make Clopidogrel slightly more effective by helping with that activation process. And then finally, medication compliance. Obviously, if you don't take the medication in the first place, it's not going to work very well. And that sounds really obvious, but statistically speaking, 1 in 6 patients will actually not fill their Clopidogrel prescription following a hospitalization for a heart attack. Then finally, there are some unknown factors that we just don't have a lot of data for. So age, weight, for example, could be diet, environmental factors, could also play a role in how effective Clopidogrel is. But the factors listed on the slide here are the main players that we're well aware of that are also supported by literature. Now, if you take all of those factors into account, the genomics plus the environmental factors, about 40% of patients, depending on the ethnicity of the patients in a study, will have an inadequate antiplatelet effect with Clopidogrel. Now just think about that for a second. 40% of patients, when we test to see how effective that Clopidogrel is, 40% of the time it is not very effective. Now you might be asking yourself, well, how do you know it's not being effective or not? Are you waiting for patients to have a heart attack? And the answer is no. Actually, what you can do is there's a test called Verify Now. And that Verify Now assay is a way to see how reactive a patient's platelets are with the fact that they have Clopidogrel or a P2Y12 inhibitor on board. So this Verify Now assay will give you a number, and that number is in PRUs, P2Y12 reaction units. And if that number is high, it would indicate that their platelets are too reactive and that they have a potentially poor response to Clopidogrel. Now the threshold is slightly variable. The main study that supported this threshold was called the Gravitas trial, and they used a threshold of 230 PRUs. So if you're above 230, then you had a poor Clopidogrel response. But then they did some post-hoc analyses and said, well, around 208 was kind of the sweet number within our study that indicated a higher risk of heart attacks and strokes and things like that. So somewhere between 208 and 230 is a reasonable cutoff. Now, if you're a patient and you're less than that 208 to 230 PRU, then we would say, hey, great job. You have a good Clopidogrel response indicating that your platelets are not very reactive and that the Clopidogrel is, in fact, doing its antiplatelet job. Now, if you're curious what a typical or an average PRU number is, obviously it's going to depend on genomic factors and environmental factors, but a typical patient is going to have a number about 150 with a standard deviation of 73. And about 60% of the time, you will see patients that are below the 230 PRU threshold. This actually comes from the Gravitas trial, which was primarily Caucasian patients. So you would expect this number to be worse in terms of fewer patients having low PRU values if you include more Asian patients as an example, who typically are more inclined to have a 2C19 variant that makes them not activate Plavix as well. So the Verify Now test is to test the antiplatelet effect. We also have tests to actually look at your 2C19 phenotype to see, what alleles do you have specific for 2C19. Now, the main player in this space is called the SpartanRx system, and this is really interesting because it's a buccal sample. So you basically swab the cheek of a patient, and it will look to see, does the patient have a star 2, a star 3 or a star 17 allele present. If that allele is present, then it would report that. And if it doesn't detect it, then the assumption is that the patient is probably a star 1, although we don't know that for sure because they're not testing all of the other alleles between star 4 and star 16, although all of those alleles are incredibly rare to see. The other form is a blood sample, and most of the blood samples on the market at least test for the same alleles, star 2, star 3, and star 17, which are by far the most common alleles present, although some of the other tests may test for additional variants as well that would have very rare circumstances for those to come up. Now, one reason why the SpartanRx system is becoming fairly popular is because it was actually used and is currently being used in 2 large randomized controlled trials. One is called the Taylor PCI trial, and that actually has not been published yet, but the other trial was called the Popular Genetics trial, which has been published that we'll talk about in a second here. And both of these large RCTs use the SpartanRx system, and again, a huge advantage is a buccal sample as opposed to a blood sample, and you can get your results within 1 hour. And for the blood sample, it just depends on which manufacturer you go with. So in terms of that verify now, we get a PRU number, so a platelet reactivity unit. One option could be that we just give bigger doses of clopidogrel to kind of overcome the fact that our PRUs are too high. Or maybe we just pick a different agent that doesn't have the genomic issues that we have with clopidogrel. And the other 2 P2Y12 inhibitors in the market are prasugrel and ticagrelor. So we actually answered one of these questions in terms of should we give that larger clopidogrel dose in a trial called the Gravitas trial. And what they did was they took about 2,000 patients that had PCI, so they had a stent, and they selected out the patients that received clopidogrel, and despite the clopidogrel, still had high PRUs, indicating that they had poor antiplatelet response. And basically what they did was they randomized these patients with poor clopidogrel response to increase their clopidogrel dose to 150 milligrams a day, so 2 tablets a day, or the standard control arm was the 75 milligrams once a day. Their primary endpoint was an efficacy endpoint of a composite of cardiovascular death, heart attack, stent thrombosis at 6 months. They also had a safety endpoint of moderate to severe bleeding, and then a surrogate endpoint of basically asking the question, did the PRUs get better in terms of did they become responders of clopidogrel after 30 days of being on the higher dose or the standard dose? So the results of the trial, their primary efficacy composite endpoint was literally not different numerically, and the p-value was not significantly different. So there was no efficacy benefit to doubling that clopidogrel dose. And they looked at bleeding, and interestingly, numerically, bleeding was less common with the higher dose, although with that p-value, this is just statistical noise. There's no difference between the two groups with respect to bleeding. Really, all they could show was the percent of patients that had elevated platelet reactivity units. So again, in this case, it was above or equal to 230. If they were still above 230 despite having that bigger dose, what they found was, yes, there was a significant difference in terms of the percent of patients that had high PRUs still, which is a bad thing, was 40% as opposed to 62%. And this is a surrogate. So even though they could make Plavix more effective in terms of its antiplatelet effect, there was no difference in bleeding or in efficacy in terms of the cardiovascular endpoints for the trial. So based on this, we don't do a double dose of clopidogrel or something like that because we were unable to show an efficacy difference. So the other question is maybe we should just pick a different P2Y12 inhibitor if we think that the clopidogrel is not going to work. And this was studied in what was called the Popular Genetics trial. And as opposed to looking at PRUs, they looked at alleles. So they looked at the star 2, star 3 alleles, which are loss of function alleles with clopidogrel. And in this study, the Popular Genetics trial, they took just under 2,500 patients that had STEMI and percutaneous coronary intervention, so a stent, and they randomized them to either get genotype-guided therapy, where they did 2C19 testing, and they looked for either a star 2 or a star 3 allele. If they found it, they then advised the provider to give the patient either prasugrel or ticagrelor. It was up to the provider to decide. If they could not find the star 2 or star 3 variants, they just continued with clopidogrel. Now the control arm was just giving the patients prasugrel or ticagrelor and avoiding the use of clopidogrel entirely. if you're asking yourself, okay, how often would patients get prasugrel or ticagrelor if it was basically up to the provider to decide? The vast majority of these patients got ticagrelor if they were potentially indicated for that. So numerically speaking, in the genotype-guided arm, about 61% of the time, these patients who were randomized to that arm got clopidogrel. About 1% of the time, they got prasugrel, and then the remainder, which is 38% of the time, they got ticagrelor. So again, about 40% of patients genotyped positive for at least one star 2 or a star 3 allele. In the standard treatment arm, 91% of patients got ticagrelor, 2% got prasugrel, and then 7% of them actually did get Plavix for some other indication or some other reason that they couldn't tolerate therapy that they were assigned to. It was an intention to treat, so they did allow for this to happen. In terms of the results of the trial, so again, we're comparing genotype guided, where you could potentially get one of 3 P2Y12 inhibitors, versus the control arm, which was you either got prasugrel or ticagrelor, mostly ticagrelor. So the primary efficacy endpoint was, did you die? Did you have a heart attack? Did you have stent thrombosis, stroke, or a major bleed? They started with a non-inferiority analysis, and they showed non-inferiority, and they did not prove superiority. So what this means is that genotype-guided therapy was just as good or not non-inferior to just giving the patient prasugrel or ticagrelor. Now, where the study got really interesting was looking at major or minor bleeding events, and what they found was a pretty good reduction in the number of bleeding events if the patients got genotype-guided therapy as opposed to just getting prasugrel or ticagrelor, with a significant p-value. They also looked at major bleeding, which was a secondary endpoint, and there was no difference. You can see the confidence interval crosses 1 here. So really the take-home point here is that genotype-guided therapy is as good as giving prasugrel or ticagrelor. However, from a safety endpoint, bleeding was more common if you got prasugrel or ticagrelor versus if you got genotyped to see if you were eligible to get clopidogrel or not. What makes this study really interesting is that this is really the first trial to show a pretty impressive benefit to using genotyping versus not. And this is one of the kind of holy grails to pharmacogenomics, is not just showing a difference in platelet reactivity units or a difference in some surrogate endpoint, but actually having hard clinical endpoints to really justify the cost of doing the genotyping. So very briefly looking at some of the alternative options, we mentioned prasugrel, brand name is Effient. You take this once a day. There's 2 different doses here, a 10 milligram dose for most patients or a 5 milligram dose if you're less than 60 kilograms. This is only FDA approved if you had PCI done, so a stent placed. Like clopidogrel, prasugrel is also a prodrug. However, unlike clopidogrel, it doesn't rely on 2C19. It actually uses multiple different enzymatic pathways, so we don't see a lot of variability in the response to prasugrel like we do with clopidogrel. Now, really importantly with prasugrel, it has a boxed warning that you should not use this drug. It's contraindicated actually to use prasugrel in any patient with a history of stroke or TIA. The reason is that they're much more likely to have intracranial hemorrhage if they're given prasugrel versus if they're given clopidogrel. Then finally, there are 2 big precautions to prasugrel. One is weight less than 60 kilograms. There is a dose adjustment of 5 milligrams a day. However, many clinicians will just avoid the drug altogether in that patient population. And then 2, age at or above 75 years old. Generally, we're going to avoid use because these patients also were more prone to bleeding, specifically intracranial bleeding, versus patients that were given clopidogrel instead. Now, the third P2Y12 inhibitor on the market is called ticagrelor or Brilinta. Now, one downside of this drug is that it has to be taken twice a day, but it has a number of upsides. So one is that it is not a prodrug. It actually uses 3A4 to be metabolized away, but ticagrelor, the molecule itself, is actually readily an antiplatelet agent. It does not need to be activated into anything. It also has a box warning, except its box warning is that you should not exceed an aspirin dose of 100 milligrams a day or higher. And the reason for that is that in the clinical trials, it didn't appear that ticagrelor was as beneficial versus clopidogrel at higher aspirin doses. This is actually fairly controversial, so we'll leave it at that, but that is what the box warning says. And it actually has 2 unique adverse drug reactions that aren't present with our 2 other P2Y12 inhibitors. One is dyspnea, so shortness of breath. And in terms of the incidence rate, this is a pretty profound difference of 14% versus 8% with clopidogrel. And if you think about the patient population, we're looking at patients that just had a heart attack. So to have new onset shortness of breath after having a heart attack could be very alarming. as would ventricular pauses, almost double the rate of ventricular pauses. Now, the reason for both of these side effects is presumed to be because the chemical structure of ticagrelor is fairly similar to adenosine that does have these side effects, which is also potentially why we only see the side effect profile with ticagrelor but not with clopidogrel or prasugrel. Now, for a very long time, prasugrel and ticagrelor were basically FDA approved on the basis of being compared to clopidogrel. And we typically don't have head-to-head trials of new drugs, especially if there's a drug on the market that they can be readily compared to, like clopidogrel in this case. So it's really interesting. As of October 2019, there was a trial done called the ISAR React 5 trial. And it looked at just north of 4,000 patients that had acute coronary syndrome, so this could be STEMI, NSTEMI, unstable angina, with a planned PCI strategy. So all of these patients were planned to have a stent placed. Now, they randomized these patients to prasugrel or ticagrelor. Again, this is very rare that we have two branded products that are being compared head-to-head to each other. And they had an efficacy endpoint of death, heart attack, or stroke at 1 year, and then a primary safety endpoint of major bleeding. Now, just to set the tone here, prior to this trial, based on the phase 3 trials of these two drugs versus clopidogrel, prasugrel tended to have a worse bleeding profile versus what we observed with ticagrelor versus clopidogrel. So at the time, we didn't have head-to-head data, but based on kind of indirect evidence, we assumed that prasugrel might actually be a little bit worse, which is kind of evident in the popular genetics study where we didn't see a lot of prasugrel use when it was an option in the trial. So what did we actually see? So in terms of the trial results, we saw a significant difference of 6.9% versus 9.3% in favor of prasugrel. So prasugrel is actually a little bit more effective, mostly by reducing the rate of non-fatal heart attacks, but really all of the endpoints really drove this as well. Now, typically in cardiovascular trials, if you have a better efficacy endpoint, you often have a trade-off with a worse safety profile, specifically bleeding. But numerically in this case, prasugrel actually had less bleeding. It was not a significant p-value, which is fine. But what that means is that we saw an efficacy benefit without compromising safety, which is really hard to do. So at this point, the ISAR React 5 trial is really new. And because of that, we don't have a lot of new guidelines to really put this into perspective. So you're still going to see plenty of ticagrelor, but this is absolutely going to be a sticking point in terms of where guidelines go in the future in terms of picking one versus the other. So on that basis, if you were to look at the CPIC guidelines, what do they recommend in terms of antiplatelet therapy? So if you are an ultra-rapid or an extensive metabolizer, meaning that you don't have any loss of function alleles, we would expect either to have normal efficacy if you're an extensive metabolizer or increased efficacy if you're a star 17 allele carrying patient. And they recommend, sure, go ahead and use clopidogrel if you'd like to. If you're an intermediate metabolizer where you have one, but no more than one of a loss of function allele, so this would be like a star 1, star 2, star 1, star 3, something like that, we would expect some degree of reduced efficacy of clopidogrel, and the guidelines do recommend considering prasugrel or ticagrelor, an alternative P2Y12 inhibitor, but this is moderate recommendation, meaning that they don't have great evidence supporting this, but they do have some data that says that this is a reasonable recommendation. Then finally, our last category is a poor metabolizer, where these patients have two loss of function alleles, either 2 star 2s, 2 star 3s, or one and the other. And we would expect to have very reduced efficacy of clopidogrel. And in this case, it's a strong recommendation to consider prasugrel or ticagrelor, again, an alternative therapy. So where do we go from here? So in terms of conclusions, one big thing is that it's not just about genetics. So even though this is a pharmacogenomics lecture, we talked a lot about environmental factors and clinical factors that you really have to take all of these into account. Just because a patient is a star 2 doesn't mean that they must be given a non-clopidogrel option if they potentially are contraindicated for those other therapies. At this point, the data supports testing PCI-only patients. For the most part, we're not testing in clinical trials anyone who hasn't had a heart attack and then had a stent put in at this point. And then finally, based on the ISAR React 5 trial, really the big question is going to be, in those who are indicated to not get clopidogrel because either they have high platelet reactivity units or they are this intermediate or poor CYP metabolizer of 2C19, what do we do for them? At this point, the guidelines equally prefer ticagrelor, and prasugrel. But again, based on some new data, maybe we will start favoring one agent over the other in the future. Really, time will tell, and potentially even more data will tell at that point.